here, especially the psychiatry residents who, are taking time from your schedules as well, and certainly appreciate those of you in practice doing a lot. I was thinking as I was getting ready this morning, I was thinking of the old adage that we used to say when we took dermatology about, about the skin. We'd say if it's dry, wet it, if it's wet, dry it, and then if it's not better, use a steroid. And I kind of feel like that. We tell people, well, if they're aggressive, calm them. If they're calm, don't upset them. And if you can't help what's happening, call the psychiatrist or something like that. But we really want it where they can call any of you, and you can reach us through the DCPAP program, and we'll be happy to help in any way that we can. I just wanted to start also by saying that for today's talk, I have a number of slides that I'd like to show, but please interrupt along the way because I'd rather have discussion than just do slides. And, I'll get through the essential things regardless. So I just wanted to show this to start. This modified overt aggression scale, the MOAS, is a nice scale if you're trying to get a measure of aggression. It monitors aggression over the course of the past week. It has 4 domains of aggressiveness. It gives a weighted numeric score. You'll see at the bottom that the scores are weighted. And obviously, physical aggression is the highest, the most weighted component. It's nice to have these rating scales because they add to like the PHQ-9 that many of you are used to already for depression, or the GAD-7 for anxiety, for kids that are showing aggression as well, so that you can monitor over time how they're doing and progressing with whatever your interventions are. So you'll be able to print that out if you like afterward. Contributing factors to aggression, and some of this I know will be review, but they're genetic predispositions and actually epigenetic predispositions. The temperament of the specific child, parenting style. We find that sometimes if there's substance use disorder in the family, not only are kids neglected in terms of their needs, which can be frustrating for them and ultimately lead to aggression, but sometimes they're hurt by other people that may be involved with the people that are using drugs or under the influence. And so there are different reasons we can see it there. Certainly where you have difficult marriages or relationships, if they see adults being aggressive, they can imitate it. Trauma is a big one. Trauma can cause PTSD, and one of the factors we see in PTSD, besides depression or anxiety, can be aggressive behavior. And certainly exposure to peer influences, if somebody's being bullied or seeing people being bullied, and if they identify with the aggressor, we can see that. Now, I'm going to talk about some different components that lead to it. Irritability, we know, is transdiagnostic, meaning you can see irritability as its own issue, but it's really involved in a lot of different things. Developmental temperament, again, sometimes if kids are feeling sick or they have a medical illness, and these varied psychiatric issues, including disruptive mood dysregulation disorder, that DMDD disorder, the other ones you can see. And irritability often indicates underlying anxiety and depression more than bipolar disorder. I thought I would mention that. We do see kids with bipolar disorder, and those kids can have irritability, but they tend to have more mood shifts that affect their sleep, their appetite, their energy. So when you see this irritability, more often that's coming from anxiety or depression, and then you have to get to the root of that. So because these diverse factors influence the aggressive behavior, practice guidelines tell us that we have to be careful in how we think about the psychopharmacology, and I'll talk about that in a little while. This is just a factor in irritability, and it's just a diagram out of the American Journal of Psychiatry. And I thought it was helpful because what it shows is that kids that become very irritable they either overvaluate the reward, and then when it's denied, their frustration gets very higher than what a typical kid's might be. So they have this atypical reward processing. And also, if they feel threatened because they're not getting something, they're frustrated, and they're not having what they feel they need or they want, that threat processing, if they feel like it's being taken hostilely, if it's being taken to deprive them, things like that, they can be like hyper-oriented to it. And those things can lead to irritability and sometimes to aggression as well. Risks of irritability, you know, in the long term, if you don't deal with it with kids, they can carry irritability into teenage years, college years, and adulthood. And it can actually get in the way of things. I worked with a woman one time who she had had premenstrual irritability for years. And at work, whenever it was around the time that she would become more irritable, she would be so difficult and so aggressive, she was at risk of being terminated from her job. And besides getting therapy to deal with some of the hurt and domestic violence she'd been through, we found that a little bit of an atypical antipsychotic really calmed that irritability for her, and it made a big difference in her life going forward. And she's just a very pleasant woman whenever I've run into her. And again, that reward processing, which can be off in kids and youth that show irritability, if they don't have some cognitive flexibility, it makes it difficult not only in terms of their frustration level, but when you're trying to talk to them and get them to see a different perspective. So being able to adapt to change and to more adult rewards and negative reinforcements, that's important to work with as they get older. Some of the non-medication interventions for irritability, obviously you want the differential diagnosis, and then you want to address the source of whatever the excessive discomfort is. So whether it's coming from trauma, whether it's coming from something somebody said, whether it's coming from that they're very sensitive to what's going on with somebody else, whether they're distracted, whatever, when they become excessively uncomfortable or discomfortable, that can lead again to buildup of more irritability and sometimes on to emotional dysregulation, which we'll talk about. Antidepressants and anti-anxiety agents tend to be the things that we use. And so the SSRIs, especially, sometimes low-dose benzodiazepines in older youth, sometimes Vistril, can be used to help take some of the edge off that anxiety acutely. We have other things we've used off-label like gabapentin, but the main thing is that these classes tend to help with the irritability. Now, if we move to emotional dysregulation, you can have that in people who are irritable all the time, like kids with disruptive mood dysregulation disorder. But you can see emotional dysregulation in people who, in between times, they're not very irritable, but they still become emotionally dysregulated. They have trouble managing their emotions, their feelings, things that are new and novel. Sometimes we see that especially in kids with autism spectrum. We see it in kids that are in new learning environments, and they can become easily upset. And if they don't have sufficiently developed executive functioning and sort of a calmer sense of self, they can be very reactive. And sometimes you can even have they even perceive things so negatively that it overwhelms their normal executive functioning. And that's where you'll see a child that usually is very well behaved, does well, and then all of a sudden they'll have an outburst in your office, or the parents will say, I don't know what's going on with them. And you have to kind of find out what the underlying source is of this dysregulation. You get anger, the common one we hear about in kids is when they're told no. but it can be frustration in themselves or with somebody else. Anger can be verbal, but it escalates sometimes to rage and to physical aggression. And conflicts, past experiences, emotional sensitivities, fear can all lead to those intensifications of anger when somebody's upset or reactive. So anger plans, you want to keep an appropriate tone of voice. You have to judge, and this is whether you're doing this in your office, in a hospital, in a school. Regulating that closeness distance is very important. Some kids want you to be in closer if you can be empathic, where they can feel safe and nurtured. Other kids, you get too close, they will feel frightened, or they'll feel more rageful because you're in their space, and they'll blow up. So modulating and regulating is your own behavior while you're teaching them to regulate theirs is very important. And then obviously, I like this picture too, keeping the appropriate tone of voice we talked about, but also giving alternatives to current behaviors, alternate outlets, activities, as well as distractions. Now, sometimes you can do that verbally, like if you have a child that's really upset and they're ranting a lot of verbal things, sometimes just a calm approach and saying it's going to get better, we can talk about it later, whatever, especially if they're still on the way up and not into their full outburst. On the other hand, some kids have pent-up energy when they're really upset. And sometimes just letting them run a little bit can make a difference. I've had kids in the office where whether they've got ADHD impulsivity, or they're angry at a parent and they get ready to stomp their parent's foot or something like that, I open the door and I let them run up the hall and run back and sit down again. And sometimes just having that physical outlet for some kids works really well. Now, when anger takes over and it's expressed with a lot of intensity, you actually have a lot of rage. And there, when you have rage, you have to start providing calming alternatives and setting distance, because those kids in their rages can throw things, they can lash out, they can hit other kids, they can hurt people, they lose disrespect sometimes for adults. And rage is something that is very intense, and we treat it because, we treat it a little differently than like a regular mood swing, because if you can take the edge off it emotionally, physically, with medication, if you can take the edge off rage, people can calm back down, and in the future have more ability to process the anger without going into a full rage attack. And I'll talk a little bit about how we treat that with medication. But in the meantime, diagnoses that can be associated with aggression, there's a whole list of them. I'll just let you take a quick look through there. I don't think any of those things would surprise you. One of the things we see in kids at school a lot is that they're frustrated with their learning. There are kids with learning difficulties. And as most of us know, to succeed in school, you've got to have very good verbal skills. To succeed in other areas outside of school, if you have good nonverbal skills, you can work on a lot of things. You can be a mechanic. You can develop all kinds of new designs and bridges and all kinds of things, artwork, whatever. But school mandates good verbal skills, and some kids don't have them. And sometimes it's under-recognized if they haven't been tested. And so some kids will feel overwhelmed and like the expectations are too high for them. So that can be one that comes. And the other one is monitoring for both victims of aggression and those who are currently causing the aggression is important. And if you can determine that that's going on, it really helps to be able to, when you refer to the school, back to the school administration, you don't just want to refer the victim. That's very important to protect the child that's being hurt. But you also want to make sure there's intervention for the person doing the bullying, because if you don't look into that, if you don't monitor or face that, then you miss the issues going on in the bullying behavior that may be coming from someone who's been a victim previously, is now taking it out as identifying with the aggressor and causing bullying. So you want to catch those things to take the risk out there. So I had mentioned that rage can become aggression. And when you have aggression, sometimes if you're in a hospital setting, sometimes you've got a containment area or holding area. But even in schools, I noticed, like the school I consult in down in Seaford, it's a wonderful setup they've got. They've got several rooms that are very low lighting. They have things that kids can't get hurt with in there, like some, large soft plastic balls and some other things that they can use to help calm themselves. And they actually have it monitored by someone who can keep appropriate distance. And so some of the kids learn to go to this room when they're getting really, really upset. Other times it may be right in their same classroom. There's an area in the classroom they can go, or near the classroom. It depends on the child and how much they're feeling shame, how much they're feeling need, and how much guidance they get. But no matter how it's delivered, it's important that they know that people care, that they're empathic, because most of the time when kids are that upset, they want to be able to calm. They just don't know quite how to do it. So now sometimes we look at medications again, and this is from the literature. If you have someone with a history of ADHD and they are showing rage and aggression, a lot of times raising the dose of their stimulant or adding some guanfacine or guanfacine ER can be helpful for them. It can also help with oppositional behavior. Now, if you have kids that get into rage and they're aggressive, physically aggressive, Depakote valproate or Depakote ER can help. We use that in boys. We tend to use oxcarb in girls just because we don't want to increase risk of polycystic ovarian issues. And there's also, we will use oxcarbazepine in boys who won't get a lab study or are gaining weight on Depakote. We usually don't see a lot of weight gain on the Depakote or the oxcarb alone, but if you have Depakote combined with other medications, sometimes we can see high weight gain, especially with an atypical antipsychotic. So we try to, if we have to use Depakote for rage and you have somebody who also needs, say, an antipsychotic because they have bipolar disorder or autism spectrum or schizophrenia spectrum disorder, then we want to pick an atypical antipsychotic that's less likely to cause weight gain. Now, also lithium carbonate is a good medicine when the other things don't seem to be working, especially when bipolar or bipolar 2 is present, or if you have a lot of self-injury and suicidal threats. Lithium carbonate's actually shown to decrease the aggression. It obviously, you'll want to carefully monitor the level and follow some other labs, but lithium by and large is safe in even use in young kids as long as they're not they're taking in sufficient fluids and they're not getting overheated and sweating excessively in the summer. So these are just a couple other background things for violent behavior from our American Academy of Child and Adolescent Psychiatry. These are just some facts for families. Factors that increase the risk of violent behavior. I think we've covered a number of those, but even exposure to violence in the media, social media and TV can actually aggravate aggression in some kids. For some kids, it seems like it's an outlet. They can play a video game, an aggressive video game, and it gets rid of their tension. But other kids, actually, it builds their tension, and it also teaches them aggressive solutions. So we always want to have things balanced with parental and school input that shows appropriate social skills and appropriate anger management. So some of the warning signs. I think we already recognize these. We talked about irritability, we talked about intense anger, we talked about frustration. And the best way to head off violent behavior is to head it off at the pass. If you can catch kids on the way up and intervene and prevent them from a major outburst, it really helps. Now, you can't always do that, but we have some success with that once we know what sort of drives or triggers that child. And so being able to get a good evaluation, find out what some of the triggers are, the next thing we like to do, and I'm going to talk about this now rather than later, one of the things we like to do is to set up role plays. And the important thing about role plays is that you want to do it when the child's calm and the parent's calm, so that they can practice it in a low-key manner. But you have to prescribe the practicing, because you can have them try it in your office, like your mom's sitting there, you're angry at her. Let's say you're angry at her. Are you gonna, what's gonna help you calm down? And some kids will say, well, if I can go to the other room, but I don't want to be out of the sight of my mom. Okay, you still want to see your mom so you know she's there, but you want to be away so that you can calm your anger. So then we have them role play going to a place in the hallway or a place in another room where the doors open between them and they can see the parent and the parent can see them. But then they have to practice that at home a number of times when they're calm, or they're not going to remember to do it when they're upset. So role play is so very important. And obviously we're finding ways to help decrease violent behavior in kids. And some of the things down below are some of the identification, monitoring their viewing of violence, and prevention of child abuse, which we had talked about earlier. Agitation. Now, agitation, I kind of see that as being a little bit different than rage and aggression. Agitation can present as a kid that's upset or looks angry, but agitation is usually it's like an inner upset that is driving them. So they might be fearful of something, they might be having a hallucination, they might be having a traumatic flashback, they might be having a mood swing, and they become agitated due to this distress. And sometimes, again, we want to look for the source of agitation, but these are the situations where if you contact us, we'll try to guide you through the use, if you're not already familiar with it, of an antipsychotic medication. Because I have found that generally the atypical antipsychotics tend to help more with agitated kids, whereas the Depakote and the Oxcarb tend to help more with raging kids. And I know there can be kids that have both. Sometimes they end up on two medicines, or we find that, the antipsychotic helps with the rage in some kids as well. But it's good to look at different sources. We know that they help in those who are agitated because of personality difficulties and they can't regulate their mood very well. Like someone, we have youth with borderline personality features that, they either love or they hate, and both at the same time. And that tears them apart. And it takes them a long time to learn the shades of gray in between that they can adapt to. So for those kids, when they're really out of control, that antipsychotic medicine can help, or it can help prevent more episodes. Kids with autism spectrum, if they have real bad sensory sensitivities, or they can't make a transition from, say, this learning group to that learning group, or this class to that class, or they have a lot of perseverative behavior where they're asking something over and over and they can't seem to get the answer that they want, agitation can be a component, and that can calm. And then they're also helpful, as we know, with bipolar spectrum, schizophrenia spectrum, premenstrual agitation in young women. And so there are a number of ways that we try to calm things, both in terms of behavior and medicine. CBT interventions. This is just one. I just thought I would open with this one. It's from one of the clinics, child psychiatry clinics of North America. And it just shows CBT for depression, CBT for anxiety. And I think many of us know some of those interventions already, and then behavioral treatment for conduct problems, including effective instructions, active ignoring, but also intervention when you have somebody that's doing something that's going to get somebody hurt. So I'm just going to kind of go through these quickly, and you can ask any questions you like, and you'll have this deck to look back at. But trauma-focused CBT, cognitive behavioral therapies are very helpful interventions for kids who are upset. And I know next, in a few weeks, Marky and Pazuniak, one of my colleagues in the DCPAP program, will be presenting some 5-minute behavioral interventions for kids. So you'll get a more detailed view of actually in the moment calming. But I had already talked about pre-rehearsal for tough situations. And as most of us know, positive and negative reinforcement work better than punishment. Negative reinforcement is when you remove something that's upsetting the child. If you can ameliorate that, remove it, that's a negative reinforcement. Positive reinforcement is when you give them something that they find supportive, helpful, enjoyable, whatever. So whereas punishment tends to lead to more anger in the long run. So we try to limit the punishment and help more with negative reinforcement and positive reinforcement. Consequences, consequences aren't always punishing, especially if they're delivered in a caring manner. And the big thing I found when I talk with teachers that have really good luck with their kids in class and parents that have good luck at home is you want to keep your consequence as short as possible. Kids know when they're being consequented. They know when the parent's setting a limit on something they did wrong. And, saying, I'm taking your cell phone for the next 6 months is a lot less effective and likely to be argued with and overcome and not be a good thing. Whereas you're not going to have your cell phone again for a couple days, depending on the age. Or teachers will start the next day and say, yesterday's past, today's a new day. How are we going to do today, and what can we do to help today? And so even if you have to time someone out, or even if they had a really rough day, you don't want to come back in the next day and really rub that in their face. Now, sometimes you have to look at consequences, like maybe they have to apologize to someone, or maybe they have to fix something that they broke. But that's usually in a calmer situation than at the time that the outburst is occurring. These are ones that most of us have tried in the office, deep breathing, counting. And again, it isn't just a cognitive thing. You have to have them practice it, and then you tell them to practice it at home when they're calm with their parent, and you have them pretend a situation and how they get through it using these strategies, and including, again, having an activity to let out the energy. Some kids, when they're stuck in a seat, can actually let out energy by journaling or progressive muscle relaxation, because journaling, we tell them that the anger and the energy are coming out from their body through their arm, and that it's coming out the pen into the paper, and they can look at it later about what they were upset about or discuss what they were upset about. Progressive muscle relaxation, where you tense up and then relax muscles starting higher up. You can have kids have the anger go into the chair they're sitting in and down into the floor. But some kids, you actually have to let them get up and move. And that's hard, because if a kid's upset and you tell them to move, you're not always sure where they're going to move to. So you want to direct where they can move safely. External supports. for executive functioning difficulties. You know, sometimes the kids, their executive functioning gets overwhelmed, and so they have trouble with these kind of things. And some of them will accept guidance in these things before they end up being upset. Sometimes if they're not getting guidance, if they're not getting cueing, if they're not getting redirection, that's when they get more and more frustrated. And that's when you see outbursts. This is good. These are some de-escalation strategies that I thought I would show. This was presented at our annual meeting in 2021, and I thought it was a great list. So I'll just let you take a quick look at that. And I had already talked a little bit about raising the stimulant medication dose first in ADHD youth who are becoming aggressive. And they found that if that wasn't working, I would tend to go with divalproex first if they are showing more anger, and that risperdone's been shown to help with agitation as well. And so you get a choice of agents, and remember that you're always trying to give medication, not just within an environment of parent and child education, consent and assent, but you're trying to show them how the medication can give them more self-control, which can lead to more independence, which can lead them to getting more of what they want. And that way it's not seen as much as an external thing being thrust upon them. So this is what we had talked about. And other anti-aggression medicines. We had mentioned these. The point I wanted to make on this slide is that antidepressants don't generally have a major role in treating childhood aggression. They're great for depression, they're great for anxiety, but they're not so great for aggression unless the aggression is directly coming from anxiety. Sometimes, like kids with PTSD, sometimes will do better with an SSRI. Some of them will also do better if they have a little bit of prazosin at night. That seems to take the edge off some of their nightmares and their intrusive memories the next day. And again, some of the things we use, clonidine, guanfacine can help with, especially with kids with ADHD, but any kid, the clonidine can make them a little sleepy, and it's calming, and they tend not to have big blood pressure changes. Guanfacine, same thing, and doxepin in very, very low doses, 10 milligrams or less, and you can open the capsule to take it out. But that very tiny amount of doxepin, it doesn't have, it's an antidepressant by history, but it has no antidepressant effects at that level. And fortunately, has no other of the side effects that made it such a miserable antidepressant, except it still makes people sleepy. So sometimes I believe it's safer to give them a little bit of doxepin. If you want to really calm them down and you're not worried about them going to sleep, doxepin may be safer sometimes than using thorazine if you're in a higher level care setting. Sometimes we also use Vistril and other meds to help take the edge off anxiety and agitation. Okay, and finally, I think we've talked about some of this adapting for a school setting, but you want to have kids be able, obviously, to be in class most of the time, but if you can have a study carrel or two in the classroom that a kid, if they're getting a little upset, especially a teen, they can go to do their work, not get hassled, no shame, anybody can go there. That sometimes works. If not, a lot of times teens will get a pass to go to a wellness center, or they'll go to talk to the school counselor or the social worker, and that gives them a way to get away, talk about things, come back. And then where you have a kid that gets really agitated at school, that they can also go sometimes to a separate room or to see a separate person at the school. Some people are close to the resource officer. Some of them are close to a guidance counselor. Some of them are close to a particular teacher who may be free at some point. We do see kids, though, especially younger kids in classrooms sometimes, where when they become agitated, they might start throwing things or hitting. Sometimes there, the teacher needs to decide, do I remove the child from the situation? But if the child's really upset and having an outburst, you have to be careful because you don't want to get hurt trying to grab them. And teachers aren't really supposed to be holding kids down and things like that. They call for help. So sometimes they have to clear the classroom of the other students so that the other students are safe and that the student in question can get the interventions that they need right there in the class. And then you want to contact the parents, because some kids, if they can just talk to their parent or their caregiver when they're upset, it will actually help them calm. I know in some settings they'll say, well, when you calm down, we'll call your mom, or when you calm down, we'll call your dad. That isn't always going to work for these kids. They might need to talk to the mom or dad first. So it's not that you're giving them a reward. You're actually helping them to calm themselves, which again, then you can give positive reinforcement for that. So these are some of the things that help in special education classrooms for defiant kids. One of the things I found going into a classroom that down in Seaford, the school I was at, they had a special classroom for kids that were truly disruptive, aggressive, and defiant. And I thought, anybody that can manage a class full of kids like that has to have some secret. So I went and I sat in the class and I observed. And what I found was they kept the kids busy. They would work at their desk for maybe 10 minutes. Then they'd go over, they'd look out the window to take something outside that they were going to look at and write about. Then they'd come over and they'd sit on the floor for storytelling time. And then they'd get back up. And when you had a kid that was a little more disruptive than the others, the teacher would give them something they could do. Like, why don't you come bring the eraser up and erase the board for me? Or why don't you, stand up, take a breather and we'll move on. And just by keeping these kids busy, redirecting them, not shaming them, seemed to make a big difference in that kind of a classroom. And the big thing was the teacher was not afraid of the kids. It was a male teacher, but he was not a big, gruff kind of male teacher. And I'm sure if these kids, they were physically capable probably of hurting him, but the way he managed them was just wonderful. So I just wanted to pass that on because, sometimes it's hard to think about what to do when you've got someone who is very disruptive. And we're almost done here. So these are some interventions for explosive outbursts at school. We talked about some of that already. But look again, about 1/3 of students with such behaviors fail to graduate from high school on time and remain at high risk for later life dysfunction. The other thing you find is that kids that are older, if they're held back a grade, let's say they have some learning difficulties along with their aggression, then they're a bigger kid in the next year's classroom. Like if they're repeating a grade, they're older and bigger than the other kids in the class. So when they reach a certain point, if they're not in special education, they may actually get expelled from school if they're seen as being aggressive because they're older and they're approaching an age where they can be expelled. So we really want to try to help kids when they're younger hit the right trajectory. And here's a few other key points that I'll let you take a look at. And you'll see again by these that you really have to customize the intervention to the child. And there's further research going on. I just wanted to show for those of you that are researchers or going to be researchers, they're actually doing research on dysregulation and irritability. And these are some other resources that are available to you. So that's my presentation. So with any time left, any discussion, questions, even observations would be welcome.
Please feel free to unmute. Even a case vignette would help us with our discussion.
I have a question. This is Dr. Zork.
Oh, hi.
Hi. I had already used this as a consult recently with the DCPAP, but can you reflect sometimes on maybe during a certain period? I have a patient, for example, who's a teenage girl with intellectual disability and history of ADHD, and she had periods of regression. Can you talk about like ramping maybe up on a dose? She's on risperidone, and whether, you know, it's okay to go back down if there's a particular episode of aggression that seems to have calmed down and she's doing well. Tell me a little bit about that. Or you keep patients on medication, look to be able to go down again in certain cases.
So it's a reasonable question, and you know, sometimes it depends on what's going along with the intellectual disability. Like some kids with intellectual disability might also have, you know, like bipolar 2 mood swings, you know, where they get really down and withdrawn for a while, and then they pop up and they have a lot of energy, and they're not really recognized as bipolar because they're not always aggressive, but they do have those mood swings. So sometimes, again, when they get more cycling, you probably would want to raise the dose if they're not on an excessive dose of risperidone, or if they're gaining excessive weight, you know, you can switch them over to Geodon. You can switch them over to an older style one like profenazine, or you can look at Latuda, you know, which tends not to cause weight gain. And so it does help. And what I have found is if kids are acutely agitated to the point that they need medication, it can take more medication to calm them than what they need ongoing. Like now, if somebody has schizophrenia and they're having hallucinations and you have them on medication, every time you cut back, if the hallucinations pop through, you've got trouble. But kids with aggression, as they learn other ways to manage, and even intellectually disabled kids can learn how to manage that aggression a little bit, especially with a lot of cueing, a lot of oversight, a lot of redirection, if it's done calmly, then you can back down on the medication, usually, I found, and they can still do well. So, and again, if they have ADHD as a component, sometimes having a little more stimulant or some guanfacine or clonidine can make a difference so that you don't have to use as much of the atypical antipsychotic. And one other thing with intervening with intellectual disability, somebody had taught me a long time ago that if you're trying to teach somebody with intellectual disability how to do something differently, and there are a number of steps involved in doing it differently, that you have to start with the last step first. Practice that one a lot until they have that. Then you add the next step before that. So they used an example of, like, you know, somebody that gets frustrated when they're told to do the wash. And so instead of saying, well, you need to take the clothes down and you need to put them in the basket and you need to put the basket in the washing machine and leave it there, you know, the clothes from the basket, you have to start with helping them take the clothes from the basket, put it in the washing machine. Then when they've got that down, then you work on having them take the clothes and put them in the basket or bring the basket down. So you work backwards, and they say that tends to work better. But I found with intellectually disabled kids, sometimes they're uncomfortable in some way, physically, emotionally, and you have to kind of tease that out of them because they may not be able to express verbally what they're feeling or what they're experiencing. And so that those behavioral and training interventions seem to help some too. Does that answer your question?
Yes, thanks.
Yeah.
Okay.
Hi,
Hi.
Dr. Oh, go ahead.
So the one thing I found was like sometimes the kids who are very aggressive and we see the aggression, but sometimes there seems to be an underlying anxiety which doesn't come out as much. And unless we add like an SSRI for the anxiety, they get better with some aggression, but still there's unpredictable outbursts because we don't even know like what's triggering them. So with like the autistic kids and the intellectually disabled nonverbal kids, sometimes that's for one kid, I like for years and years tried everything. I think I've consulted you too. And finally, something made me start like propranolol, and that really helped with us, with this aggression. And the other thing too, nowadays, they're like recommending simultaneously starting metformin with the risperidone and or the Abilify to prevent the insulin resistance and weight gain. So I've been doing that now. So
Yeah, as of there are lots of things people have tried to lower weight gain on antidepressants that tend to cause weight gain. And olanzapine, now they've got a product out there with buprenorphine and with the olanzapine to try and limit the weight gain, because some kids they only respond to olanzapine for some certain chronic illnesses. But most kids that are not on schizophrenia spectrum can respond to a number of different ones. So it helps if they're doing well on something. And kids will gain, even on Abilify, they will gain weight, a number of kids. And so adding metformin can be helpful. It's been shown, of the things we've got to give, it's been shown the one that works best. But I can tell you, I've had kids on risperidone or other meds where they were gaining weight, and I added metformin, and I don't think it may have helped their metabolics, but I don't think it really helped their weight. So the big thing is monitoring weight and making sure that if somebody continues to chunk on pounds, you don't wait, because kids don't get used to it and then level off in the weight gain generally. If you start an antipsychotic and they're gaining, say, a pound a week, if you leave them on it for a year, they'll have gained 50 pounds because it doesn't level off after a couple of weeks. It just keeps going. So you're better calling and we can help you switch over to something different. But I agree with you. If you have, kids that are experiencing underlying anxiety or depression, those kids do respond to the SSRIs and the antidepressants. So I'm glad that you thought to try that, because before you get into more serious kinds of medication and stuff, it's wonderful when you can get somebody, where you really tackle that, both with the medication and with your caring interventions, which I know you
using
do.
it at the same time as the risperidone helps too, like, right, both together, or sometimes you need both.
Mm-hmm. Yep. And sometimes we do use both together. We see a number of kids that require both. But again, my thing, whenever I put kids on more than one medicine, and I end up, working in a residential center, you end up with kids that are on lots of medicines. The thing I always try to do is show how the medicines together are making a difference and helping hopefully keep the dosage of either or both of those medicines lower than what it would be if you were using that one medication alone. So thank you.
Hi, Dr. Orr. I have a
Hi,
question.
Naveed. What's up?
What is your experience with clonidine, especially in kids who have simultaneously ADHD and those who are specifically on stimulants, and they fall more on the side of rage, not the agitation?
Okay.
Given the fact that, Depakote can be a good option, but a lot of population, we can't do the blood work for Depakote levels. So, as far as my patient population, I have seen that clonidine does help, especially for rage. Especially, I heard from some of the supervisors that it helps in road rage. So that's why I wanted to, yeah,
That's good to know.
yeah, it did. Yeah, one of the very senior supervisor shared his experience with clonidine, that it worked for someone who had a road rage.
Wow.
Yeah.
Wow. That's good to know. Well, clonidine, it's nice. It's an alpha adrenergic, not blocker, alpha adrenergic
Centrally,
medication. Yes. Yeah.
centrally acting. Yeah.
Yes. And so what's nice is as long as somebody's not over sedated, you can even use it during the day. Even if you have to use a half a pill, a half of a 0.1 milligram, and it can help. And if it's not helping the rage, see, if it's somebody with ADHD, it may be especially helpful because you're helping calm the impulsivity, which can be behind some of their anger and then their rage. But if it's somebody else and they're benefiting, that's great. If they're not, and they're not really prone to going to labs, I tend to use oxcarbazepine more. It isn't that labs shouldn't be checked with oxcarb, but there are less frequent liver and white blood cell count and platelet count effects with the oxcarb than there is with the Depakote. And I always warn people, some people have, there's somebody in the family that can take and keep the kid calm or even hold them down during the blood draw. I try to show kids just on their arm with my finger where the needle goes when it goes in, because I think kids have this fantasy that when that needle goes in, somebody's going to like jab it down in their arm and it's going to go down into their elbow or their bone or something. And if you show them that it just goes along, it just goes under the skin and right into that vein. For some older kids, they get that and that helps. But if they really won't go for a test, I try to give them all the warnings of, liver function changes and, flu-like symptoms when nobody's got the flu and things like that, so that at least if they were to develop symptoms in between an appointment with me, they're at least going to go somewhere and find out what's going on and perhaps consider stopping the medicine.
Okay.
But I haven't had a lot of trouble with oxcarb. Depakote, sometimes in youth, especially African-American youth, they can be a little more prone to, the white cell count drops. So have to keep an eye on that.
Okay. Thank you very much.
Sure.
I just want to share one more thing.
Sure.
There is so clonidine, essentially, it's a short-acting medication, may last like a couple of hours, but there's long-acting form of clonidine as well.
Yes. Yeah. Capve is the brand name of that.
Kids, yeah, that may help, especially for the kids who are not driving or during the day they're agitated, and we require more support in terms of the number of hours for keeping.
Yeah, a lot of us tend to use the guanfacine first, or the guanfacine ER first, because it's less expensive than the long-acting clonidine. But with a prior authorization, you can usually get the long-acting clonidine if you want that smoother effect during the day. And one of the things, again, this is just a tiny bit of advertising. Our DCPAP program's available to any of you that are registered. You can give a call. We've got 5 psychiatrists, available to do encounters with you. Most of you here have used that service. The other thing we're doing is we've got a collaborative care model going with one of the bigger pediatric practices, and that's going well. And we've recently started in a local high school, actually having a registry and reviewing students, patient unidentified, just like with our encounters. We don't know their names, but the school knows their names, and we give them information. And then sometimes if they need, let's say they need therapy, we've got resources to help with that. If they need a medication or a diagnostic evaluation, we try to get them to their primary care, who can then use the DCPAP service to help the student at school as well. So we're trying these programs because they've been shown to help, and there are big scalable models that are being used in some states, but in Delaware, we have a small supply of psychiatrists, child psychiatrists, and so and pediatricians are very busy, and so are family practitioners and family medicine docs. I mean, and so we have to have these sort of boots on the ground kind of ways of meeting these needs. So feel free to give us a call, and if your practice is ever interested in developing a collaborative care model, the big insurers are paying for it. The Medicaid carve-outs in Delaware are paying for it. They pay for the codes. And so we've got people that could help set it up, and then you can, get paid for, the primary care practice can get paid for what they're doing. So it can be really helpful. So
Dr.
thanks for letting
Bohr.
me say all that. Yes.
Oh, no, I appreciate all of your expertise and for helping to bring us back to the review of DCPAP. I hope folks have looked in the chat and made sure that they have my email address. I can be your direct or indirect contact, both to DCPAP, to Dr. Bohr, to information about this session and future sessions, mindy.web@delaware.gov. I so appreciate, again, you sharing this important topic in this first of our small cohort sessions around managing behavioral health needs of patients in primary care. And for those of you who did not register ahead of time, everybody will be receiving a copy of the slide deck. I'll make sure that I have your email. If I don't, please find me. So you can get both a copy of the slide deck, information about how to get registered with the Medical Society of Delaware to get a free CME credit, information about how to find this recorded session in the future for enduring viewing on our learning management system, and invitations to future sessions as well. We're going to have a training on Halloween, October 31st, as Dr. Bohr mentioned, with Dr. Markey and Pazuniak of Christiana Care around DIY for difficult kids, 5-minute behavioral interventions.
That
Same
should be really
format.
good.
Yes, and that will also, I know metformin is discussed in that session. I'll give you a sneak preview, but that session is from 1 to 2 p.m. We're varying the times to make sure we reach as many folks as we can. But look out for that invitation as well. And I so appreciate everyone sharing their time with us today. I wish you all a great rest
Thanks,
of the day.
everybody.
Please keep up with us via email, and thank you for attending today. Take
Dr.
care.
Bohr, thank you very much.
Oh, you're welcome.
Thank
Take care.
you.
Hope to see you again.
Thank
care.
you. Thank you. Look for my email probably by tomorrow with this information.
Thank you.